Dr. Sujithra.
Thank you, Dr. Thomas. So we're coming to visual field defects in neuro-ophthalmology. So when to do field test? So when the patient complaining of defective vision, and when we examine when there is no obvious ocular cause for defective vision, then we do visual fields. And also sometimes the patient itself say that there is some visual field loss. Okay. So visual field examination is important to localize and identify the disease affecting the visual pathway, and also to monitor the disease, whether it is improving or worsening. So visual field and retina are related opposite. The nasal retina represents temporal field and the temporal retina represents the nasal field with respect to fovea. So normal visual field extends 60 degrees superiorly and nasally, and inferiorly the field extends to 70 to 75 degrees, and temporally the field extends to 100 to 110 degrees. And physiological blind spot corresponds to optic disc, and it is located 15 degrees temporal to fovea. So technique to evaluate visual field, the automatic visual static perimetry is usually done. We can do either 10-2, 24 or 30-2, and we should take only the reliable field. So when the fixation loss is less than 20% and false positive or false negative response less than 30%, we take that field as reliable. Okay. As explained by the previous speaker, the retina and optic nerve disease can have field defect, and usually the optic nerve and the retinal disease respect the horizontal meridian. As you can see here, quadrant enopia, central scotoma, ring scotoma, and arcuate scotoma, and hemifield defect. In optic neuritis, you can get central scotoma or centrocecal scotoma or paracentral scotoma. And in papilledema, early papilledema, the field is usually normal. When there is, when the papilledema is chronic, we can get either enlargement of blind spot or constriction of visual field. As you can see here, there is constriction of visual field. That is an indication for intervention, acute intervention to prevent visual loss or optic atrophy. In AION, we get altitudinal field defect. So bitemporal hemianopia we get in chiasmal lesion, and pituitary tumor and craniopharyngioma is the common tumor which causes bitemporal hemianopia due to the involvement of crossing nasal fibers at the chiasma. So here you can see pituitary adenoma causing bitemporal hemianopia initially. When the disease progresses, the field defect involving the nasal side. Craniopharyngioma causing bitemporal hemianopia. As the disease, here you can see the progression of disease and involving the nasal field inferiorly. So in retrochiasmal visual pathway, when there is lesion in the retrochiasmal area, you get contralateral homonymous hemianopia. When the hemianopia is incomplete, it helps in localizing the lesion. When it is complete, then we can say the lesion is anywhere from the optic tract to occipital lobe. So coming to optic tract lesion, so optic tract lesion causes contralateral homonymous hemianopia, RAPD, and botatrophy of the optic nerve in the contralateral side. And in the ipsilateral side, you get temporal pallor of the optic nerve. So coming to lateral geniculate body lesion, it is very rare. So here again you get homonymous hemianopia, and when the lesion is very localized, when there is involvement of anterior choroidal artery ischemia or posterior choroidal artery ischemia alone, we get homonymous sectoral anopia, and it is very, very, very rare. And coming to optic radiation lesion, Here the postsynaptic fibers from the lateral geniculate nucleus are involved. So inferior fibers passes through temporal lobe and superior fibers passes through parietal lobe. So the field defect also differs accordingly. So temporal lobe lesion, we get superior homonymous hemianopia. Usually it is incongruent. So parietal lobe lesion causes inferior homonymous hemianopia, usually called as pie in the floor appearance. So coming to occipital lobe lesion, here again we get contralateral homonymous hemianopia. The characteristic feature of occipital lobe lesion here is the field defect is congruent, as the nerve fibers, the corresponding retinal nerve fibers are very close to each other. We get congruent field defect. So when we get congruent field defect, we should think of more posterior lesion. So tip of the occipital lobe, sometimes we can get central homonymous fields are represented there. So we get central homonymous field defect, and here the blood supply is dual. Both the posterior cerebral artery and the middle cerebral artery supplies here. So occlusion of PCA, that is posterior cerebral artery, can result in homonymous field defect with sparing of macula. So here we can see the homonymous hemianopia with sparing of macular central field. So lesion of the tip of the occipital lobe can be due to ischemic or space occupying lesion. So here we can get small homonymous scotomatous defect if there is inadequate collateral circulation. So here again you can see right homonymous scotomatous defect due to ischemia. So bilateral lesion in the retrochiasmal pathway causes decrease in visual acuity, and the visual defect is usually symmetrical in both eyes. So when to do 10-2, when the field defect involves up to fixation, it is better to do 10-2 to examine the field in detail. Okay, here we can see that field defect involving up to the fixation, and 10-2 field showing the field defect is more in the left eye than in the right eye. So this is the flow chart depicting the how to we come to a diagnosis seeing the visual field defect. So when the field respects the horizontal meridian, the field defect is usually due to retinal or optic nerve pathology. When it respects vertical meridian, it is due to chiasma, from chiasma to posterior lesion. Okay, coming to one important field defect which I come across, I'll share this with you. This is a 34-year-old lady, and her main complaint is difficulty in locating a small moving object. On examination, her visual acuity is 6/6 and by 6. Color vision was normal, fundus was normal, and field examination showed central scotoma, both eyes, and it is repeatable and reliable. And field defect was involving central 20 degrees, but her vision is 6/6 and N6. So then we did 10-2, so which showed that field defect sparing central 10 degrees. So possibly it is due to ischemia of temporal branch of posterior cerebral artery which caused this problem. And she gave history of severe headache before this episode, possibly due to migraine causing ischemia, bilateral ischemia. So another case, she is a case of optic nerve glioma. She is under follow-up from a long period, from 4 or 6 years back. So initially her vision was 6/60 and she had mild proptosis and RAPD and mild temporal pallor of the optic disc, and you can see the visual field. Then after 5 years, when she reported to us, her visual acuity improved to 6/9 and there is 1 millimeter decrease in proptosis, but the fundus disc pallor was persisting, and definitely there is improvement in field defect. So there is spontaneous resolution of optic nerve glioma it is being reported. So visual field defect helps in localizing the site of lesion, and also when we follow them regularly we can assess the disease whether it is improving or worsening. Thank you.
Thank you, Dr. SUJITHRA. We can take questions.
Okay. If no further questions, we can wind up the sessions. Thank you very much.
Thank you.